I am the CEO and co-founder of CarePort, and we are a care coordination technology company that bridges hospitals with post-acute care. So all of the nursing homes, home health agencies, hospice, all of the needs that patients have after a hospital stay. We connect the two together and enable smooth transitions from hospital and out into the community.
And you've been around for roughly 10 years, and I think your clients include ACOs, maybe some payers, as well as some providers, correct?
That's right. Our customers are hospitals as well as post-acute care providers, and many of our health systems are taking on risk. So we are in over 1,000 hospitals. So as you can imagine, a fair number of them are in various risk models, whether it's bundles or ACOs. And through our work with risk-based entities, we've also started to work a lot more with payers over the last couple of years, especially as providers and payers continue to come together.
Yeah, there's kind of a blurring of the line of what used to be a pretty bright line between payer and provider. That's
right.
So I wanted to talk to you today about a new beast in the value-based care menagerie. It's called direct contracting, and it's a new model that I'm familiar with. Direct contracting that's happened in the private sector between healthcare systems and some employers. But CMS has developed a new program, that direct contracting, that I think is getting underway, and it's being couched as being something of a successor to ACOs. So could you just give us a little one-on-one on what this direct contracting model is exactly, and how it is the same as well as different from ACOs?
Sure. I've heard a lot of buzz about direct contracting, as I'm sure you have, both from our provider customers as well as the health plan side. I think we're hearing a lot of chatter about the promise of direct contracting, and at the end of the day, it's a new CMS program to bring more providers into risk-based arrangements. So empowering providers to care for the patient holistically, because they're not just managing the care of that patient, but also the costs associated with caring for that patient, right? So it gives providers more incentive to think about what in healthcare we call the value. What's the trade-off between the care, the quality of care, the cost, and how do we deliver high value care?
Sure, that's an element of all these value-based models, but my understanding is that the direct contracting and what are going to be called direct contracting entities, that unlike some previous care models, which, to use maybe a hackneyed metaphor, were built on the chassis of fee for service, that these direct contracting entities are going to be paid much more in a real way, in a capitated form, where they will get a global payment, and it won't be there won't be sort of the fee for service payment cash flow with reconciliation at the end that we see with a lot of the current risk models. Do I have the right end of the stick here?
I think so. I think in the way that I would think about direct contracting too is that I think it's a way to sort of expand in terms of what ACOs have been able to do. So I think what CMS was anticipating when ACOs came out was that through ACOs, people would learn how to take on risk, right? And that eventually what we would see is that ACOs may become sort of the precursor to MA and being able to sort of take on the MA business, right? And we would see that. And I think to some extent we've sort of seen that a bit. But what we also know about MA is that for the provider to sort of transition to a full-blown MA plan, there is a lot more involved than just knowing how to manage the risk of the patient. I mean, there's networks and how do you certify your networks and the contracting elements, the reporting. And so the way that I think people are talking about direct contracting is almost a way to encourage more of those providers to take on more risk and more Medicare fee for service members without all of the sort of the complexities and infrastructure that you need to set up an MA plan. And it's a way to get some of the best parts of the MA plan, like the supplemental benefits piece, which we started to see with next generation ACOs, again, without, all the infrastructure that one would need to sort of stand up an MA plan. And so I think that's why people are seeing this sort of as a successor to ACOs, because instead of making that jump from ACO to MA plan, how do we continue to bring these provider organizations along through direct contracting?
Just a couple more questions.
Yeah.
So is there, as it's currently proposed, is there one of these on-ramps to two-sided risk that have been a feature of ACOs? Or if you become a direct contracting entities, is it two-sided risk right off the bat? And for those who aren't familiar with the jargon, I'll try to do a two-sided risk means that if you beat a financial metric, you share some of the savings, you get some additional money. But it also features downside risk, which is to say that if you exceed a financial benchmark, that you actually pay, in some sense, a penalty to CMS for going over your budgeted amount. So does direct contracting, first of all, does it have that shared savings, shared losses framework baked into it? And am I correct that there's either no on-ramp or a shorter on-ramp to two-sided risk?
It's definitely sort of higher risk, sort of higher reward than maybe some of the early versions of what we've seen before, which was maybe upside only, or to your point, sort of one-sided. And right now there's sort of two participation options. As you know, there's that professional option, which is a lower risk arrangement with sort of 50% savings and losses, which provides that sort of capitated risk adjusted monthly payment as well for some of those enhanced primary care services. But there is sort of that savings losses component, and then the global option, right, which is much more sort of the highest excuse me, risk sharing model, where you have the primary care capitation piece, as well as sort of the total care capitation piece as well. So it's a steeper on ramp than I think prior models, and even within the steeper on ramp, there's one that carries a huge, not a huge amount of risk. Well, I guess providers would say a huge amount of risk, and one that it's slightly more modified.
Just a couple more questions. I hope you don't mind if I take advantage of your expertise here. So you said that this is supposed to induce people into entities or providers into a new value-based arrangement. What exactly is in it for them? What would be the allure to become a direct contracting entity, as opposed to being an ACO?
Right. So I think it's, there's a lot of sort of the technical details that sort of improve upon the ACO model, in terms of benchmarking methodology and risk adjustment. There are some criticisms of the way that sort of that ACOs were held accountable to costs, and every single year that they would have to do better, and they were sort of competing against themselves. There's been some modifications to that to sort of take away a little bit more of that dynamic under this model. So I think there's been improvements and sort of lessons learned here. And then what we talked about too is that there's these sort of supplemental benefits that are also available. Much more flexibility in terms of what type of benefits you can give to patients, to better engage them in their care. So whether that's transportation vouchers, or nutrition services. You have a lot more flexibility to address the patient as a whole rather than just the medical, because I think what people are learning is that sort of the medical and the social are very much tied together, and so you have more flexibility to really sort of think about cost holistically. And from a provider standpoint, the reason why they would do this is because, as you know, under fee for service, they get paid one rate, right? And that's sort of the rack rate. And here it's sort of, if you do really well, you can make a lot more than that rack rate, because of the savings that you're able to generate. And so, and I think with ACOs and the models that came before, here you can even take on a wider swath of the patient population. And what we know is that that's all of that scales, right? Like, you can't build out a care coordination team for 5 patients, versus, because there's a certain sort of level of overhead associated with it. And so this gives you access to more Medicare fee for service population that can come under your wing and help you continue to scale some of those, pieces that you put in place to manage the patient across the continuum.
Just a couple more technical details, and then I want to really talk about what CarePort, how this is going to change things for you and CarePort. Just to be clear, these direct contracting entities, as far as the patient is concerned, might manifest themselves as some additional benefits that you've just addressed. But I'm going to be an attributed patient. It's not like I'm going to sign up to become a customer of a direct contracting entity, correct? I mean, it's still kind of operating from the patient's perspective in the background. Is that correct?
Yeah, I think from a patient perspective, the primary way sort of into this is through your physician, right? Your physicians that are aligned to it. I do think that in addition to the supplemental benefits that we were talking about, Peter, though, that one of the things that's unique about direct contracting is that it's bringing payers into the fray as well, right? So under ACOs, it was very much hospital based or physician organization based. And what we're seeing is that payers are aligning. There's a bit of a scramble right now in terms of payers trying to align with physicians who have experience delivering care in this way, where they're looking at patients across the care settings, where they're used to managing risk. And the reason why I think payers are so interested in aligning, and I think it was great from a program design perspective that they are allowing sort of these sort of payer provider collaborations, is that these payers are seeing this as an opportunity for them to expand their Medicare business, right? And so in an ideal world, you're getting the Medicare business obviously through the growth of MA in your MA lives, but direct contracting offers another way for you to get at these sort of Medicare fee for service members. And bringing this back to your question of, what does this mean for the patient? I think what patients oftentimes don't like is that it seems that the provider side and the health plan side are very siloed, and that they're separate, and that sometimes what we hear even from patients is that, oh, there's a payer team that's reaching out to me, there's a provider team that's reaching out to me. I don't want to get 5 different calls from 5 different care coordination teams that never talk to one another, right? And I think with DCE, I think we're going to see more alignment of payers and providers because there's a financial incentive for both. And that hopefully should break down even some of the silos that we see today, to your point, those bright white lines of payer and provider. I think this continues to kind of blur that. And I think that will be positive for the patient.
Well, let's turn to CarePort here. So you are a care coordination company. You've been working with ACOs, and as we said at the top of the conversation, some providers, also some payers. So is direct contracting sort of a a major new line of business for you, or is it just another? Is it just going to be another bar in the bar chart of like of who you do business with and how many customers you have and what the revenues are? I'm just wondering if this is a how fundamental this is for a company like yours who's been in the business of care coordination.
Yeah. Um, it's a great question. I think there still remains to to be seen, what the adoption rates are. I think what everything I'm hearing is that this is going to be sort of a major thrust in value-based care and getting more providers into value-based care. I would say for us at CarePort, a lot of what we do is to help providers take on risk because we give them visibility into what's happening to their patients in the hospital or post-acute care setting. And you need that type of visibility to manage patients across the continuum, right? You can't just get the claims information, 90 days later and then try to care coordinate then, because by then it's too late. The patient's already in the hospital, they're already readmitted. And so you need some of that real-time visibility. And that is especially challenging in the post-acute care space because it's such a fragmented market, right? There's so many mom and pop skilled nursing facilities and home health agencies. And so how do you really track those patients and ensure that they're getting the care that they need, and that the care is appropriate, that they're not going to a nursing home and then just bouncing back to a hospital. So those types of that type of visibility, that need to sort of coordinate care, I think spans whether you're in a bundled arrangement, whether you're an ACO arrangement, whether you're in direct contracting. And what we see from health systems is that when they're building out this type of infrastructure, they're not just doing it to get the bundles business. They're doing it because they see an opportunity to take on risk through bundle, to take on risk through ACO, now through direct contracting. They may have value-based contracts even with the plans that sort of are tied to some of these measures. And so I think for us, we've been in this risk world of helping our providers taking on risk, having that visibility across the continuum, managing the patients across different settings of care. And so we see this as sort of just another avenue for providers to take on risk and be successful in managing a swath of patients. So from that perspective, I would say it's not a radical shift, but it's funny, Peter, I haven't heard this much buzz about a program, even as I think back to ACOs or bundles. And so it feels like that this could be something that is much wider, but time will tell. Time will tell.
Yeah. Do you have any thoughts on why is there buzz about this? At a certain level, it's just another value-based contracting arrangement. I say this facetiously, so what? We got a jillion of them.
Right.
Welcome to the club, direct contracting. So, what? Any thoughts on why it's sort of buzzy?
And this is sort of, I would say, sort of opinion, right? Now we're entering into the realm of opinion versus the nuts and bolts of direct contracting. I would say that there's probably something to be said about the shift to value-based payment doesn't happen overnight, right? People need to be led there, right? That's why CMS wasn't so radical even in the first couple of models that they rolled out. There was a lot of sort of upside, carrots to try to pull people along. And I think each of those programs on their own have sort of made an impact, whether it's readmission penalties to bundles, to ACO, to next generation ACOs. And, are we now at sort of that tipping point where with direct contracting, it's like the model came along at sort of the right place, right time. And there's already been sort of a groundwork of shift that people are ready to sort of jump in 2 feet much more into direct contracting than they were in the past because of all the sort of that softening and warming of the market that has
So,
happened in the last
so,
couple of years.
so you're sort of suggesting that this might be a tipping point phenomenon.
Yes.
Yeah.
The other piece that I think is different is that there's been a push um, from the payers, right? Both in terms of their own contracts with the providers that have pushed them along in the same way that CMS has pushed them along to take on risk. But I really think that on the payer side, there's a lot of push or pull, I don't know how you would say it, for them to align with these providers, because they see this as part of their strategy to winning MA lives, which is such a core component of the growth strategy of all these plans out there right now. And so I wonder if it's a bit of sort of, we're at this sort of moment in time where maybe we're starting to approach that tipping point. And two, there's much more of a pull from payers than we've ever seen. And especially since that they see this as sort of a key part of their growth strategy of how do we get these Medicare lives? Is it just going to be through MA, which is what we've traditionally focused on, or do we now see opportunities with DCE? And what happens if DCE does become a big thing and we're not a part of that, right? So I think those are some of the things that make this maybe a little bit different in terms of the moment in time. But I feel like for everybody that has said the ACOs, I mean, that's going to be the thing, it's so hard to say.
It's this would open up, here we're at the end, and I don't want to open up a whole new can of worms, but I wonder at some level with a direct contracting from if depending on the frame you draw around this whole area, whether it's in some sense competition with MA plans, or whether the providers are some providers anyway, are wondering whether this is sort of the MA plans, sort of MA plans way to sort of come in and take away business. I don't know. But just one thing I wanted to ask you about, getting back to CarePort. So wondering whether you could just unpack with maybe a couple concrete examples, what you mean by visibility.
Yeah.
That's a convenient term, a little bit jargony. But could you just, I don't know.
Yeah. No, definitely.
Explain it to me the way you would at the neighborhood block party if it ever happens again.
Yeah, and I'm guilty, Peter. I mean, it's like the more you spend in healthcare, the more you start to talk this language that
we spend a lot of time trying to get fluent in it, and then
yeah, exactly. What I mean by visibility, and the way that our customers think about it is actually, in some ways very concrete. So what we hear from our customers is sometimes they're trying to manage, oftentimes they're managing risk for these patients. So managing when a healthcare expenditure is actually occurring, right? Somebody goes into the hospital, $10,000. They don't have any idea that has happened until 90 days later when they literally see the bill. And so it's like trying to manage your spending. Like think about even your credit card spending. It's like trying to manage somebody else who has your credit card, but you don't get to manage them until you see the bill when the credit card company sends the bill. So what we're trying to do is give care coordinators actual real-time information about when their patient's going to the ED, when they're getting discharged, when they go into a nursing home, how long they're there in a nursing home, so that care coordinator can do things to try to manage those events so that they don't happen again. So for example, if a care coordinator knows that a patient has gone to the hospital, they're going to reach out to that patient to see, hey, do you have a follow-up appointment with your primary care doctor scheduled after, right? Hey, you now need a home health nurse to come into your home. Did they actually come into your home? Because a third of the time, a referral is made, and for whatever reason, the visit never happens. And then if you don't have a home health nurse in your home who's supposed to be helping you with your medications and all that type of stuff, then guess what happens? You bounce right back to the hospital. And so there's a lot that you can do if you can have real time information about what's happening to your patient, so that you can see, hey, is there an intervention that I can do? Is there some follow up that I can do? Those are all the things that real time visibility enables you. Otherwise, it's very hard to manage the cost of the patient after the fact. It's hard to prevent something from happening when it's already 90 days has already passed. So those are the types of things that we're delivering to our customers so that they can proactively manage these patients.
And is this care coordinator that you referenced, is this somebody that works for your client, or do you have care coordinators who keep track of this stuff and then pass on the information to your clients, or is it both?
We are a technology company, and so thus far, our the people that are the care coordinators are care coordinators that are either employed by the health system, the physician practice, or the health plan. We do also work with many companies that are managing these patients on behalf of the health plan that may have their own care coordinators who are using the technology. So we see a lot of care coordination models out there. And I think people are still kind of figuring it out, right? When does it make sense for the health plan to reach out? When does it make sense for the provider to reach out? A lot of that is still sort of being worked out as people are figuring things out on the ground in terms of these models.
Yeah, care coordination, easy to say, I guess really hard to do. So I think we need to leave it there. My understanding of direct contracting is sort of an accretive process. And I'm going to sort of marinate in this subject for, I think, for the next, little while. But I think talking to you, my understanding, went from sort of below the waterline to maybe I'm just getting some air. I think I mixed a metaphor there terribly, marinade and swimming. But anyway, thanks so much for your time today.
Yeah, no, it's a pleasure to speak with you. I think we're all in the same boat around direct contracting. It's hard to make sense of all of this. I think like a lot of these sort of models, it's an exciting model, and it's the right thing to do for patients.